Hello everyone and welcome to this lecture on ulcerative lesions of the oral cavity. This is the part 1 of two series lectures, and my name is Dr. Lahari Telang, and this lecture series will be covered in conjunction with Dr. Ajay as well, and we will be covering it under oral pathology and oral medicine. The learning outcomes would be to define an ulcer, to classify oral ulcerations, and to differentiate between oral ulcerations based on their clinical presentation. An ulcer is defined as a break or discontinuity of the surface epithelium caused by molecular degeneration of cells, such that a punched out area exists. There are various ulcers found in the human body, and some of the ulcers which are found in the maxillofacial region would be an aphthous ulcer, malignant ulcer, traumatic ulcer, or basal cell carcinoma, like you've seen the image over here. The second image, which is the ulcer on the skin, is an example of basal cell carcinoma. I would like to introduce two important terminologies here. One is vesicle and the other is a bulla, plural of which is bullae. A vesicle is a small, superficial, circumscribed elevation of the skin that is less than 0.5 cm in size, and it contains serous fluid. And there is a diagrammatic representation here for you to understand. Example of vesicles would be chickenpox, herpes zoster, or even pemphigus. A bulla is essentially a larger vesicle. It is a raised circumscribed lesion greater than 0.5 cm that contains serous fluid, essentially a large vesicle. Examples are again pemphigus, blisters, or the common burns that happen because of either thermal or electrical injury. These are clinical examples of a vesicle on the trunk of a patient, where you see multiple crops of vesicles caused by varicella zoster infection. And bullae, on the other hand, are larger, and you can see them on the skin as well as in the oral cavity. So both vesicles and bullae can be formed due to certain diseases within the oral epithelium as well, but they're more commonly visible on the skin, and they remain intact for a longer time on the skin because the epidermis is generally thicker and the epithelium is thinner. That's why the oral cavity vesicles or bullae tend to rupture very easily. They form within few minutes, and they can rupture very easily because you're constantly using the oral cavity, and due to the movement of the tongue or the process of chewing or even talking could cause the bulla or the vesicle to rupture. So the picture you're seeing in the oral cavity is essentially a ruptured bullae or ruptured bulla, and the epithelium, which is the tissue tag which is surrounding the remnants of the bulla. So essentially it's like a balloon filled with fluid. Once the balloon ruptures, you have the remnants of the balloon, which is very similar to the epithelial tissue tags you see in the buccal vestibule. When you're talking about history taking of a patient with ulcers, it's important to note down the following findings. The onset of the ulcer. How did it start? The duration of the ulcer. How long has the patient been having ulcers? And is the ulcer recurrent, or is there progression of ulcer? When we're talking about progression, it's important to understand that the patient could have a single ulcer and then it progresses to multiple ulcers, or he or she could have an ulcer which is smaller in size and then becomes larger. And when we're talking about recurrence, we mean how often do they recur, and is the recurrence always at the same site, or are there multiple sites involved? The presence of vesicle preceding the ulcer is a very, very important point. It gives us the idea that the ulcer is not the primary lesion, but it's in fact, the vesicle which is the primary lesion. So eventually, all vesicles and bullae, when they rupture, they form an ulcer. So it's important to understand that in these cases, which start off as vesicles, your patient must be asked the history of noticing fluid filled or bubble like blister like lesions inside the mouth or on the skin. Next is the presence of lesions elsewhere in the body. For example, if the oral lesions are accompanied by skin, eye, or genital lesions, then we're looking at multiple areas of the body being involved. Generally, you could have similar kind of ulcers seen on other mucosal surfaces or even skin involvement. So it gives you an idea that the patient is having a history of a more systemic presence of the disorder. Also, it's important to ask for concurrence of systemic manifestations. So, is the patient having other important manifestations involving other parts of the body and other important systems of the body? And is the patient on any medication, or was the ulcer induced by a medication taken by the patient? So these are some very important points that you would need to note down when asking a patient history about the ulcers. So it could be a past history or it could be the present history, or and essentially both are important. When we're talking about examination of an ulcer, we would divide it into inspection and palpation. Inspection, we will note down the size, the shape, number, the location of the ulcer, the edge or margin of the ulcer, the floor, whether it's covered with necrotic slough, and is there discharge, is there pus oozing out, or is there some form of interstitial fluid oozing out, and also about the surrounding mucosa. What is the condition of the surrounding mucosa? For example, the ulcer that you're noticing here in the picture is that of an ulcer on the soft palate. You would say junction of hard and soft palate. And the surrounding mucosa appears erythematous. The size of the ulcer is about 1 cm in its largest diameter. It is irregular in shape. There's a solitary ulcer, that's why it's called as a one ulcer or solitary ulcer. The location, I've just described it. The edge or the margin is sloping. It's difficult to actually define because it's a shallow ulcer, and the floor is covered with necrotic slough. So when you palpate the ulcers, the most important things in the oral cavity that you would be able to ascertain would be the tenderness primarily, um, edge or the margin, the base or the depth of the ulcer. Again, in the oral cavities, many a times the ulcers are shallow. Of course, if there is bleeding induced in surrounding mucosa, and if there are ulcers on the skin as well, then it's important to make a note. So let's look at the clinical classification of ulcers. Now, I'm talking about clinical classification specifically, which is derived from textbook of oral medicine, which is Burkitt's Oral Medicine. And when you're looking at a patient with ulcers, they can be classified either as acute multiple lesions, chronic multiple lesions, recurring oral ulcers, or single ulcers. Patient with acute multiple lesions, the examples would be herpes simplex, varicella zoster, cytomegalovirus infections, Coxsackie infections. The first four are all viral infections. Could also have necrotizing ulcerative gingivitis and periodontitis, which could be acute multiple lesions. Erythem Multiforming, Steven Johnson syndrome, toxic epidermal necrolysis, also called as Lyle disease, oral hypersensitivity reactions like an allergic stomatitis, or oral ulcers secondary to cancer, chemotherapy, or blood dyscrasia. So, all of these are examples of acute multiple lesions. That means multiple lesions or multiple ulcers which are occurring in a short duration. Next are patients with recurring oral ulcers. That means ulcers which keep coming back. So the examples for this would be recurrent after stomatitis, Paget's disease, and recurrent herpes simplex viral infection. So we'll be covering the herpes in both acute multiple lesions as well as in recurrent lesions. Patients with chronic multiple lesions, that means the ulcer or the lesion. Why are we using the term lesion here is that because sometimes in some cases they are preceded by vesicles, and then only the secondary lesion that remains is an ulcer. So, examples of patients with chronic multiple lesions would be pemphigus vulgaris, paraneoplastic pemphigus vegetans, subepithelial bullous dermatosis, bullous pemphigoid, mucous membrane pemphigoid, linear IgA disease, epidermolysis bullosa, chronic bullous lesions of childhood, and herpes simplex virus infections in immune compromised patients. Lastly, the patient with single ulcers would be example would be a traumatic any kind of traumatic injury which causes solitary ulceration, traumatic ulcerative granuloma, also called as eosinophilic ulcer of the tongue, and fungal infections in the oral cavity like histoplasmosis, blastomycosis, or mucormycosis. Let's look at acute multiple ulcers. An example of acute multiple ulcers would be herpes simplex virus infection. Herpes virus family has 9 different types of viruses which can affect the oral cavity. 65% of adults are generally seropositive. HSV1 infections generally occur be above the waist, and HSV2 infections occur below the waist, but there is sometimes a difference either ways also that the infection can occur. HSV1 infections can cause primary herpetic gingival stomatitis, HSV keratitis of the eyes, HSV encephalitis, esophagitis, pneumonia, and herpetic whitlow. The primary infection happens because of inoculation in the mucosa, skin, or the eye. The virus travels through the sensory nerve axons, and the latent infection happens in sensory ganglions or the extraneuronal epithelium where the virus remains latent. Primary herpetic gingivostomatitis is the infection that is generally subclinical. Children, teenagers are affected and can also occur in adults. Generally, the 1 to 3 days, the patient will have prodromal symptoms, which are fever-like symptoms, or symptoms that set in before the actual full-blown infection. The disease is generally self-limiting. The oral manifestations would be erythema in the oral mucosa, clusters of vesicle on the keratinized mucosa, and the vesicles break down, coalesce to form ulcers. Coalesce means to join together. In cases of recrudescent HSV, that means herpes simplex virus, that means infection that doesn't heal or recurs the second time when the virus in the ganglion or is reactivated, the patient could get a recurrent herpes labialis or a recurrent intraoral herpes. Now, it's important for you to understand that the first time that the patient gets the infection is called as primary herpetic gingivitis. Then the virus remains latent in the human body, and then due to certain trigger factors, you could get a reinfection. When the reinfection happens, it's called as herpes labialis or intraoral herpes, both of which are recurrent. So the trigger factors that cause a recurrence of infection are either exposure to sunlight or UV radiation, fever, trauma. Example, even a cut or a crack on the lip. Stress, simply stress due to any reason could reactivate the virus and you could end up with an HSV, herpes labialis, or an intraoral herpes infection. Menstruation, even dental treatment or surgery, the stress that the body goes through because of a dental treatment. Dehydration, upper respiratory tract infections, even like a common cold. Even though a common cold is caused by another virus, it could trigger the herpes virus to end up with causing a recurrent infection. Temperature extremes, too cold or too hot, and a weak immune system itself could be a trigger factor. So it's also important to understand that HSV infections in an immune compromised host are more commonly seen, and the infection is a lot more serious and severe than in a normal healthy person. These are examples of how primary herpetic gingival stomatitis can look in the oral cavity. You could start off with vesicles on the lips as well as the perioral skin. And inside the oral cavity, you could see this diffuse erythema of the entire gingiva. It's a very painful condition, and then there is inflammation, and it is called as gingivostomatitis. Also, seen in the picture below is an infant with multiple vesicles and crusting and erythema all over the region near the oral mucosa and the perioral skin. When the infection reoccurs, it is called as recurrent herpes simplex virus infection. It could manifest as vesicles which rupture to form ulcers on the labial surface on the vermilion border of the lip, and this is called as recurrent herpes labialis. So it's important to note the area of involvement, and this heals with crusting, and when it crusts it's called as bloody crusting because there is blood also in the crust, and they're called as cold sores. So the process of healing from herpes labialis to cold sores can take to 5 days to about to 1 week as or even 10 days. If this infectious fluid is comes in contact with the skin of even the fingers, let's say you do handle a patient who would be positively or probably infected with the herpes simplex virus infection, and even contamination with the saliva or contact with saliva also could lead to infection around the fingers near the nail beds, and this is called as a herpetic whitlow. In the oral cavity, you could see small ulcers, which is called as recurrent intraoral herpes infection. Many a times, this viral ulcers could be only unilaterally seen, or in some cases can be seen bilaterally. But it's important to understand that most commonly the keratinized mucosa is involved. As you're seeing in the picture here, it is the hard palatal mucosa, which is keratinized mucosa that gets involved. So, how do you diagnose herpes ulcers? You could do a culture of a swab, a PCR test, or smears which show multinucleated giant cells, and there is a rise in IgG titers. But generally, diagnosis is done clinically because the infection is short duration, and by the time your results of the culture would arrive, your patient would already be in a healing phase. So since it's a minor infection, generally in the clinical scenario we do not send the patient for lab tests. We would treat the case empirically, that means assuming that the infection is a herpes infection, and more so because the infection is very common. That's why you treat the case thinking that it is a empirical infection of herpes. So, what is management of herpes infection involved? In cases of primary infection, means when you're seeing it for the first time, if it's a child or a young patient, adolescent, then pain control is a primary important concern. So, you would also give supportive care like for any viral infection, and hydration, which is very important. So, pain control, which is in the oral cavity, is achieved with the help of either 2% viscous lignocaine or a dicyclonine hydrochloride or benzidamine, which are all applied topically on the oral mucosa on the affected area or ulcerated area. Acyclovir also is used. It is an antiviral drug which reduces viral shedding and infectivity, and it also reduces duration of the ulcers. So, in the oral cavity, the acyclovir is preferred for herpes labialis lesions or even a whitlow, and not generally applied inside the oral cavity. So, recurrent herpetic lesions, the I or the important aspect is to try to reduce trigger factors. and also and topical antivirals, example is acyclovir, are used. Systemic medication can be used for frequent episodes or in cases of large lesions or in cases of viral infections, specifically herpes infections, which are associated with erythema multiforme. We'll discuss this in the next upcoming slides. Also, in cases where the patient is immune compromised, you might want to reserve systemic antivirals for that situation. So, in a routine setting in the oral cavity, generally pain control, supportive care, and hydration should suffice in the management of simple, either primary or recurrent herpes labialis or recurrent HSV infections. So this is an image taken from Burkitt's The Oral Medicine textbook, which shows you various antivirals for oral herpes simplex infection. So you could either have acyclovir, famciclovir, or valacyclovir for the infection. And it varies from either usage of medication or just topical agents. This is a stepwise guideline for recurrent herpes labialis infection in adults. It's first important to ascertain whether the patient is having a recurrence and is in the prodromal stage. If yes, is the patient immune compromised? If then you would want to put the patient on famciclovir or valacyclovir. No, then the patient can take oral medication. If yes, then acyclovir cream 5 times daily, or pencyclovir cream, which can be taken every 2 hourly while awake for 4 days. So this is just a guideline to follow, and it can vary depending on the uh, immune compromised status of the patient. Let's move on now to varicella zoster virus infection. The primary infection is chickenpox. Now, as a child, many of you would have had chickenpox. The virus becomes latent in the dorsal root ganglion or cranial nerve ganglion after the primary infection. And it can get reactivated and to cause a secondary infection in certain patients, to cause secondary infection, which is also called as herpes zoster or shingles. The transmission of the virus happens through respiratory route, and varicella zoster infection can be prevented with MMRV vaccine. Hence, you would notice that the chickenpox occurrence is relatively low in the past 10-15 years because of high vaccination rate. The primary infection, which is chickenpox, generally happens in the first 2 decades of life. Fever, malaise, intensely pruritic maculopapular rash, followed by dewdrop like vesicles, are seen on the skin. The vesicles become pustular, they burst and scab with crust in 1 to 2 weeks. Lesions are seen on the face and trunk, and they spread centrifugally. In the oral cavity, you could have minor acute ulcers, but they are quite rare. Treatment plan again would be pain control, and in severe cases, patient could be put on antivirals like acyclovir, which is 800 milligrams 5 times a day, and of course, vaccination is recommended in childhood. This is an example of chickenpox and the scars that it can leave. Herpes zoster, also called as shingles, is a secondary infection happening because of reactivation of the virus, the latent virus. So in adults, generally the skin is involved, and it increases with age and immune suppression. Generally, there is prodromal deep burning pain in the area of involvement, and 2 to 4 days later, crops of vesicles occur in the dermatome. Now, what we mean by dermatome, it means that along the distribution of the nerve. So, the skin along the distribution of the nerve generally manifests with vesicles, uh, whichever nerve is involved. This pattern of distribution is called as a zosteriform pattern. It is very typical to herpes zoster infection, and the vesicles are generally unilateral, linear, and crusted. So the term zostocine eruption or zostocine herpetae means that when you have pain without any vesicles or any other vesicular eruption. Oral manifestation is generally around the trigeminal nerve. Can have vesicles in those areas which rupture to form ulcers. Ramsay-Hunt syndrome is herpes zoster infection of the geniculate ganglion. Patient manifests with Bell's palsy, vesicles of the external ear, and loss of taste sensation in the anterior two-thirds of the tongue due to involvement of chorda tympani. And treatment plan again is pain control, valacyclovir 1000 milligrams thrice daily or famciclovir 500 milligrams thrice daily for 7 days is the treatment of choice. This is examples of cases with herpes zoster. In the first image, you would see involvement of the ophthalmic division, and you can clearly see that along the midline, the lesions stop, and only the eye on the left side, along with the forehead, and exactly distribution of the ophthalmic division of the trigeminal nerve is seen here. In the second case is the ulcer seen in the oral cavity. Also, they are very shallow and multiple ulcers coalescing to form a larger ulcer. This also occurs when there is a second division of the trigeminal nerve involved, and unilateral distribution is very clearly evident. The last image here is showing thoracic involvement, again unilateral, along the distribution of the dermatome. This pattern of vesicles is called a zosteriform pattern and is very unique to herpes zoster infection. The complications of herpes zoster infection is most commonly post-herpetic neuralgia. It is a pain that lingers for 30 to 120 days after the onset of acute rash. Predisposing factors to this complication is older age, prodromal pain, that means pain that the patient had prior to the formation of acute ulcers or rash, and more severe rash during acute phase of disease means that more likely the patient is going to have post-herpetic neuralgia as a complication. Treatment plan would involve gabapentin or 5% lignocaine patches, and opioid analgesic and tricyclic antidepressants may also be used. Moving on to Coxsackie infection. This is an RNA virus. There are 23 types and generally the type A or 6 types of type B virus. Transmission is by fecal-oral route. In the oral cavity, the Coxsackie virus manifests as hand, foot and mouth disease, again which is very common in the tropics, or Herpangina or lymphonodular pharyngitis. Hand, foot, and mouth disease generally seen in younger children, generally children who are below the age of 10. There is low-grade fever, skin rash on hands, feet, which is macular and then turns vesicular. In the oral cavity, the manifestations would be sore mouth and throat, and vesicles and ulcers on any of the mucosal surfaces. Herpangina is also caused by Coxsackie virus infection. It is derived from the terms herpes and angina, which means vesicular eruptions as well as inflammation of the throat. Generally seen in children below 10 years of age, the epidemics occur in summer. Clinical features would be fever, headache, and myalgia for 1 or 3 days. And oral manifestation could be sore throat, erythema, small vesicles, and ulcerations of the oropharynx, soft palate, or tonsillar pillars. So, generally, the posterior part of the oral cavity is involved. Lymphonodular pharyngitis is a variant of herpangina with small nodules in the oropharynx region. So, if you were to look at the differential diagnosis of the viral infections that can affect the oral cavity and the oropharynx, you have herpes simplex virus. where ulcers occur in the anterior part of the oral cavity, and there is generalized gingival erythema and pain. Varicella zoster, where the oral ulcers are rare and small, but the patient would have general vesicles on skin and appears more ill. Herpangina, ulcers are generally seen in the posterior part of the oral cavity. And hand, foot, and mouth lesions are very typical, involving the hand, feet, or the mouth. And cytomegalovirus is very similar to Epstein-Barr virus. It is generally seen in patients who are already ill and immune compromised or are co-infected with varicella zoster, herpes infection, or even Epstein-Barr infection. In case of Epstein-Barr virus infection, the common oral manifestation is infectious mononucleosis, very similar to Coxsackie infection, and they can only be distinguished by serology. Lastly, you have a bacterial infection, which is streptococcal infection or streptococcal sore throat, in which case there are no vesicles or ulcers seen. And of course, culture and sensitivity can help in diagnosis. So it's important to understand here that bacterial infections do not cause vesicles or ulcers in the oral cavity, and it's the viral ones that actually cause vesicles and ulcers. So, since we're talking about acute multiple lesions, it's important to mention about necrotizing ulcerative gingivitis and necrotizing ulcerative periodontitis, which also leads to cancrum oris or noma when there's extensive amount of involvement. More of this pathology will be discussed in the periodontics, under periodontics. Now let's go on to erythema multiforme. This is an acute self-limiting inflammatory mucocutaneous disease that manifests on skin, oral mucosa, and other mucosal surfaces. There are various classifications, but the simple one would be classifying it as erythema multiforme minor, which involves less than 10% skin involvement and no mucosal involvement. Erythema multiforme major, where there is extensive skin involvement, oral involvement, as well as other mucosal involvements. Histologically, fulminant erythema multiforme may appear very similar to Steven-Johnson syndrome or toxic epidermolysis necrosis, also called as Lyell disease. But etiology and pathogenesis is different. Erythema multiforme is essentially a hypersensitivity reaction. That means it gets triggered due to infectious agents or due to medication. Now, when we're talking about factors that cause the hypersensitivity reaction, in many cases, surprisingly, HSV is actually an infection, herpes simplex virus, that can trigger an erythema multiforme like reaction. So, in cases which are triggered by HSV, mostly 65 to 70% of the cases, generally the patient would have had a history of herpes simplex virus infection 1 to 3 weeks prior to the erythema multiforme flare up. It could also happen due to a drug reaction due to NSAIDs or even anticonvulsants. Benzoic acid, which is present in food preservatives, can also trigger an oral erythema multiforme. So, when it comes to clinical features, generally this sort of hypersensitivity reaction is seen in 20 to 40 years age group, and about 20% of them are children. In cases of recurrent erythema multiforme, the patient can have an average 6 episodes a year, and the episode can last several weeks. Patient has a prodrome of fever, headache, sore throat, rhinorrhea, cough, suggesting a viral infection as a trigger factor. Skin lesions are very typical and they appear in few days. And there are multiple forms of skin lesions. That's the reason why the disease is called as multiforme. They could be beginning as macules and then become papules, starting on the hands and spread to the trunk centripetally with symmetric distribution on the face and the neck. Generally, target or iris lesions are pathognomonic of erythema multiforme, as the one seen in the picture here. Patient usually has itching and burning sensation of the skin. In the oral cavity, which happens, the oral manifestations happen about 23 to 70% of the cases, can range from mild erythema to severe, painful, large confluent ulcers with irregular bullae. Can be a very severe painful condition, as the image shown here. Patient could have drooling, blood-tinged saliva, severe crusting and bleeding of the lips, and they could also be genital involvement and ocular lesions as well. So, as differential diagnosis, primary is primary herpes simplex infection can be thought of as a differential diagnosis when there is no skin rash and the lesions are smaller. Also, you could have autoimmune diseases which can appear very similar to erythema multiforme, like pemphigus and pemphigoid, which are chronic, slow progressing, and do not show maculopapular centripetal rash. So it's important to understand that when you are looking at a patient clinically, uh, history taking is important, and chronic lesions like pemphigus and pemphigoid need to be differentiated from more acute ones like erythema multiforme. So, the diagnosis of erythema multiforme is essentially based on clinical features, and there are no specific lab findings. Management would involve pain control with analgesics given systemically or even topically, supportive care, systemic corticosteroids, antivirals for HSV related cases given at the first sign of recurrent erythema multiforme, and is known to show control of disease, specifically with acyclovir 400 milligrams or valcyclovir 500 milligrams. In non-HSV related cases, azathioprine, dapsone, and other antimalarials could be thought of as treatment plan. Stevens-Johnson syndrome is a less severe variant of toxic epidermal necrolysis. Now, both these conditions are rarely seen in the dental setting, and they are separate from erythema multiforme, although all three of them are hypersensitivity reactions. Stevens Johnson syndrome and toxic epidermal necrolysis are more severe and larger lesions and tend to arise on the chest, which are atypical targets. They also have extensive oral lesions, and the management of this patient has to be done in burns wards where they are managed with high dose systemic corticosteroids, immunoglobulins, and even thalidomide. So that nearly brings me to the end of the topic, end of this lecture, where I would be discussing additional information, that is classification of ulcerative vesicular disorders based on etiology. They can be classified based on genetic involvement, infections, reactive lesions, traumatic lesions, or ulcerative vesicular disorders occurring due to immune mediated diseases, hematological diseases, nutritional deficiencies, neoplasms, or other miscellaneous reasons. You could also have a classification based on histology as intraepithelial involvement with acantholytic or non acantholytic involvement, subepithelial involvement, and both intraepithelial and subepithelial involvement. Thank you for listening to me. The references that I've used are from Southern and Soames as well as Burkitt's Oral Medicine. For more information, please go through the lecture notes as well as the textbooks. Thank you.